There are specific joints of the axial skeleton which are classified as synovial. They have all of the main anatomy that's important for a synovial joint, one of which would be the TMJ joint, which means temporomandibular joint. And joints are usually named for the bones or the parts of the bones that actually articulate. So this specific joint is going to be an articulation between the head of the mandible and the articular tubercle of the temporal bone. And specifically, the articular tubercle fits into the mandibular fossa, which was a bony landmark that you learned on the temporal bone. So it's classified functionally as a diarthrotic joint and structurally as a synovial hinge joint. And it contains a loose articular capsule for extensive movements. It also has an articular disc of avascular, dense, regular connective tissue. As we look at the anatomy on this diagram of the temporal mandibular joint, we can see that it really has two different types of joints within it even. It has a hinge joint, so that would allow for increasing the angle between the two bones and then decreasing it. There's also a gliding joint movement where the person can actually move or protract their mandible, moving it forward. So the temporal mandibular joint is located just anterior to the external acoustic meatus and anterior to the styloid process. So the part of the mandible that articulates with the mandibular fossa is shown right here, where we actually see the temporal mandibular joint. There are some specific joints of the pectoral girdle and the upper limbs, which are synovial, like the sternoclavicular joint, the acromioclavicular joint, the glenohumeral joint, which is a multi-axial joint, the elbow joint, where the humerus and the ulna articulate, the radiocarpal joint, which is the wrist joint, and the metacarpophalangeal joint, which is at the knuckle. So the glenohumeral joint is a diarthrotic ball and socket joint, which is going to allow for circumduction. It's where the head of the humerus fits into the glenoid cavity of the scapula. You may also see it written as glenoid fossa. So it's the greatest range of motion in the body, but most unstable because it can be damaged more easily. Compare this with the hip joint. The hip joint has less range of motion, but it is more stable. So some of the features of this joint are the glenoid labrum, various ligaments, which are named for the parts of bones where they attach to, the tendon of the biceps brachii, rotator cuff muscles, which you'll be learning in upcoming chapters, as well as various bursa. Remember, these bursa are strategically located where there is excess friction. They contain synovial fluid. Looking at our glenohumeral joint, we can see the acromion, some of the various bursa. Here, for example, the subdeltoid bursa, a tendon sheath, glenohumeral ligaments, and then finally, the head of the humerus, which you can't see in this diagram, is fitting into the glenoid cavity. So it allows for flexion and extension, but also other movements as well. In the elbow joint here, we can see it allows for flexion and extension. And specifically, the ulna is going to articulate with the humerus. The olecranon is going to fit into the olecranon fossa of the humerus. The ulna has the olecranon on it. The olecranon fossa is on the posterior surface of the humerus. The radiocarpal joint, commonly called the wrist joint, is diarthrotic, and the shape of the joint is condylar between three proximal carpal bones, specifically the scaphoid, lunate, and triquetrum, and the distal articular surface of the radius. There's an articular disc which is going to separate the joint, and it allows for intercarpal articulations. In the lower limb, we see the coxal joint, commonly called the hip joint. This is the one that's going to have more stability, but less range of motion compared to the shoulder joint. This one is diarthrotic. It's a ball and socket joint between the head of the femur and the acetabulum of the hip joint. So some of the important features include a labrum, various fibers, and then some ligaments that are named for the bones that they attach. For example, the iliofemoral ligament attaches the ilium to the femur, as we would expect. With the hip joint here, we can see multiple movements, flexion, extension, as well as abduction and adduction. The various ligaments are shown, some of the bony landmarks that you've learned, and you can't see the actual articulation because of these ligaments, but the head of the femur fits into the acetabulum. The knee is shown here, and it's a very complex joint. It's actually multiple joints in one. So we see lots of supporting structures. We see some menisci, which are those shock absorbers of fibrocartilage. There's also extrinsic ligaments like the fibular collateral ligament, and those are also called things like the MCL because the tibia is on the medial side. The fibular collateral ligament is also called the LCL because the fibula is on the lateral side. And then there are intrinsic ligaments like the ACL, the anterior cruciate ligament, as well as the PCL, the posterior cruciate ligament. So we tend to refer to the knee joint as a modified hinge joint. For the foot, we have some joints that allow these special movements called plantar flexion and dorsiflexion. So dorsiflexion is raising the toes to point to the ceiling. Plantar flexion is standing on our tiptoes. And it's a joint that's between the tarsals as well as the fibula and the tibia. So some joints of the pelvic girdle and lower limbs are shown here. And those would include the intertarsal joints, which are plain joints between the tarsals, kind of like the joints that were between the carpals, the tarso-metatarsal joints, metatarsophalangeal joints, a condylar joint, interphalangeal joints, which are hinge joints between the phalanges, and the talocrural joint or the ankle joint, which is a diarthrotic hinge joint also.